Assalamu alaikum. This presentation is on pharyngeal pouches, also referred to as Zenker's diverticulum. We'll go through the anatomy and the physiology and how these pouches form. We'll also discuss how they present, how to establish a diagnosis, and the various ways of management, including success rates, complication rates, and recurrence rates. Pharyngeal pouches are not common, with a rate of less than 1 new case per 100,000 population in a year. The UK figures are almost double that, at a rate of 2 new cases in every 100,000 population per year. They affect men more, with a ratio of 2 to 1 males to females. They also affect the older age group, above the 50 years usually. The most common presentation will be between the 6th and the 9th decade. Pharyngeal pouch affect more the Caucasians and is quite rare in the Asians and the Afro-Caribbean races. The upper esophageal sphincter plays an important part in the formation of pharyngeal pouches. The upper esophageal sphincter is formed mainly out of the Cricopharyngeus muscle, with its two divisions, the oblique fibers and the horizontal fibers of the Cricopharyngeus muscle. But there is also a small contribution from the lower fibers of the Thyropharyngeus and the upper fibers of the esophagus. Together they form the upper esophageal sphincter, which keeps a continuous tone normally and only relaxes during normal swallowing. The muscle fibers of the pharynx and the esophagus are arranged broadly into two groups, a longitudinal group muscle fibers and a horizontal or circular group muscle fibers. The longitudinal muscle fibers shortens and elevates the pharynx or the parts of the esophagus on top of the preceding bolus so as to displace it caudally, while the circular horizontal muscle fibers generate pressure, intrabolus pressure, that pushes the bolus caudally as well. The longitudinal muscles include the three constrictors of the pharynx, the superior, the middle, and the inferior constrictor muscles. They act by pulling up the pharynx and shortening it on top of the advancing bolus. Part of the Cricopharyngeus muscle is also obliquely oriented, and it meets in the medial pharyngeal raphe. But the bulk of the Cricopharyngeus is circular horizontal muscle fibers. In the upper part of the esophagus, the longitudinal muscle fibers don't cover a part of the upper esophagus as well. So there is a space in the upper part of the esophagus and the lower part of the hypopharynx, which is not anatomically covered by the two sets of muscle fibers and with small dehiscences as well. This area is called Killian's dehiscence, and it is the site of formation of the pharyngeal pouches. Now, pouches can form on top of the Cricopharyngeus muscle, where there are no muscle support at all in here, or it can form between the two heads of the Cricopharyngeus muscle, between the oblique fibers and the horizontal circular muscle fibers. Pharyngeal pouches were probably first diagnosed more than 250 years ago by Ludlow in 1769. But it was Zenker and his colleagues that reported on more than 30 patients and identified correctly the site of origin of the pharyngeal pouches in the posterior part of the hypopharynx and the upper esophagus, in the weak part here, the Killian's dehiscence. Most of the pharyngeal pouches are pulsion diverticulum posteriorly, but some of them are posterolateral and very few can be lateral. And the vast majority of the pharyngeal pouches has only one opening, but more than one opening, like two, has been reported in the literature as well. A similar pulsion diverticulum that forms laterally or anterolaterally is called the Killian-Jamieson diverticulum. It forms below rather than above the Cricopharyngeus muscle, in a weak part just below the Cricopharyngeus muscle. It is much smaller in size and also very much less common than the classic pulsion or Zenker's diverticulum. It lies very close to the recurrent laryngeal nerve, and that would pose certain risks during its management. What is the exact etiology of a pharyngeal pouch? There is no broad agreement. There are three main theories proposed for the formation of the pharyngeal pouches. The first is that there is an anatomical weakness in the posterior pharyngeal wall and the Killian's dehiscence area. The second is that there is a persistent tonic spasm of the Cricopharyngeus muscle that prevents the smooth passage of the bolus and generates enough intrabolus pressure in the lower hypopharynx to cause the pulsion diverticulum. And the third is that there is incoordination between the pharyngeal and esophageal muscles while progressing the bolus caudally. The first theory on the etiology of pharyngeal pouches, that they form due to anatomical weakness in the posterior pharyngeal wall, is supported by the anatomical and the surgical findings of the Killian's dehiscence area. But it is also supported with some manometric studies that showed that the intraluminal pressure in the lower part of the hypopharynx in normal individuals and in patients who have pouches are not much different. There is no significant difference in the pressure, maximal contraction pressure in the hypopharynx between normal individuals and in patients with the pouches. And that supported the idea that it just forms because there is a weak area that can be much weaker in some individuals, and in that case a pulsion diverticulum is going to form in this area due to the high intraluminal pressure during swallowing. The second theory for the formation of pharyngeal pouches is that there is a combined increased intraluminal pressure plus impaired upper esophageal relaxation. So these two factors would lead to an increased pressure in the lower part of the hypopharynx that would cause a pulsion diverticulum out of the weak part in the posterior pharyngeal wall, the Killian's dehiscence. Two factors here: increased intraluminal pressure during swallowing plus impaired relaxation of the upper esophageal sphincter, mainly the Cricopharyngeus. This can be caused by, for example, acid reflux, and it is known that the incidence of Zenker's diverticulum is almost doubled in the cases of things like hiatus hernia. It's also known that before the formation of pharyngeal pouches, some patients may have a pharyngeal bar due to hypertrophy and fibrosis of the Cricopharyngeus muscle. This is also related to acid reflux, but can also be related to older age and neuromuscular disorders. And this would lead to impaired relaxation of the upper esophageal sphincter and high pressure causing the pulsion diverticulum. The third theory is that of impaired coordination between the pharyngeal muscles during deglutition. It was found that the Cricopharyngeus would contract a fraction of a second before the end of the pharyngeal contraction. Before the pharyngeal contraction is completed, the cricopharyngeus muscle would start contracting again, just a fraction of a second, enough to cause increased pressure in the upper esophageal sphincter that would impair the smooth passage of the bolus and creates enough pressure in the lower hypopharynx to cause the pulsion diverticulum. This was supported by some manometric measurements, which again confirmed the high intraluminal pressure in the hypopharynx in both groups, normal and patients with Zenker's diverticulum, and that these pressures were almost equal between the two groups. The difference was that the group who developed the Zenker's diverticulum, their cricopharyngeus muscles start contracting just a fraction of a second before the completion of the pharyngeal clearance and contraction. The patients with pharyngeal pouches present. The most common presentation is regurgitation of undigested food. Almost 80% of patients with Zenker's diverticulum would have regurgitation. This can happen during the meals, but more commonly after the meals, particularly on lying flat or during sleep. Some patients would learn how to evacuate their pouches before going to bed to prevent the regurgitation during sleep. This is followed by cough and aspiration and perhaps some chest conditions due to the aspiration of the undigested contents of the pouch. Patients may also complain of high but painless dysphagia, and their swallowing may be noisy. They can also complain of halitosis if there is enough retained food in the pouches, and in severe cases they may develop weight loss, and some of them would have a wet type of voice due to the contents of the pharyngeal pouch. Flexible endoscopic examination of the hypopharynx and neck examination are both essential, but they can sometimes miss a pharyngeal pouch. The diagnosis is finally made based on contrast swallow, usually a barium swallow that does not only confirm the presence of the pouch, but also allows for measuring its dimensions, which can be useful as predictors for the success of the treatment. It is known that a shorter pouch height, if it is less than 15 millimeters or so, are associated with a better outcome. The same applies for the pouch width, which should be less than 2 centimeters, and a cricopharyngeus length that should be less again than about 2 centimeters. So confirmation of the diagnosis and measurement of some prognostic factors can be achieved by a contrast swallow. The barium swallow would also be useful in the classification of the Zenker's diverticulum. Note that a single shot barium swallow may sometimes miss a small diverticulum, in which case videofluoroscopy would give a better result. The Zenker's diverticulum can be classified in various ways. There is the common Brombart's classification, which classify the pouches according to its dimension. If the longitudinal axis is less than 3 millimeters, the pouch would be like a thorn, that's number 1. If it is between 7 and 8 millimeters, when the pouch is like a club, this will be stage 2. If the pouch longitudinal axis is more than 10 millimeters, 1 centimeter, then this is stage 3, and stage 4 would be if the pouch compresses the esophagus. There are other classifications. The Morton and Bartley would classify them if a pouch is less than 2 centimeters, it's small, between 2 and 4 centimeters it's medium, and above 4 centimeters it's large. And the Overbeek and Groote would classify them according to the relative size of the vertebrae. If the pouch is less than the size of one vertebrae, it is small. If it is more than 3 vertebrae, it is large. Now to the treatment. Most of the patients with pharyngeal pouches will be elderly, and some of them will be frail with several comorbidities, and if their symptoms are not severe enough and they have no chest complications, then they can be treated conservatively. If intervention is required to control symptoms or its complications, then there are two sets of procedures for relieving of the symptoms of pharyngeal pouches. One is open by external approach through a neck incision, and that was the older ways of treating the pouches. It entails primarily division of the Cricopharyngeus muscles and some muscle fibers of the lower thyropharyngeus and upper esophageus as well. And then the pouch itself can either be resected completely, or it can be pushed back into the lumen by pouch inversion, or it can be suspended with its mouth facing downwards by attaching it, for example, to the thyroid cartilage, and this would prevent accumulation and retention of food debris in the pouch. The other way of treating pouches would be endoscopically per oral, either by the use of rigid or flexible scopes. The older ways of doing this by rigid scopes would entail exposure of the septum between the pouch posteriorly and the pharyngeal and esophageal lumen anteriorly, and then this septum would be divided either by electrocoagulation, like in the original Dohlman's description, or a laser can be used to do the same. The same can be carried out with the use of a flexible endoscope. This plot would explain why the essential part in the surgical management of pharyngeal pouches is Cricopharyngeus myotomy. This plot explains the relation between the size of the opening into the esophagus, the upper esophageal sphincter area in millimeters square, against the pressure, intraluminal pressure in the lower hypopharynx, upper esophagus, that is required to open up the upper esophageal sphincter. In patients who have pouches, you could see that they require much higher pressure to open up the upper esophageal sphincter, while in normal patients, those with the solid black dots in here, they require much less pressure to open up the upper esophageal sphincter much more widely. The results of the Cricopharyngeus myotomy would bring this into the open squares in here, which is almost similar or identical to the normal patients. That's why a Cricopharyngeus myotomy is so important in reducing the intraluminal pressure required to open up the upper esophageal sphincter more. Surgery would significantly increase the opening of the upper esophageal sphincter and reduce the hypopharyngeal intrabolus pressure as well. The steep slope in here would be normalized after surgery, and the increased compliance of the sphincter would allow a much wider opening with a much lower pressure than required previous to surgery. Which treatment modality you may need? These are the preoperative considerations. Now, success rates for the different modalities, the open surgery, the rigid endoscopy, or the flexible endoscopy, are very comparable. But the recurrence rates are different. They are as high as 19% for open surgery and 20% for flexible endoscopy, but much lower for rigid endoscopy. The other thing is most of these patients are elderly with several comorbidities, the very patient that you don't want to have any surgical complications with. Open surgery would have a high complication rate with about 30%, whereas rigid endoscopy would have about 3% serious complications and half that for a flexible endoscopy. The other factor is that for rigid endoscopy, you require a general anesthesia and also hyperextension of the neck, which can have some risk if the patient has neck problems or cervical problems, and sometimes the operation could be abandoned and transformed into either flexible or open surgery in as much as 7.7% of the cases. Although the ultimate choice between open or transoral approach depends very much on the surgeon's expertise, but some factors should also be considered. There should be an adequate exposure of the pouch by the endoscopic route. If this cannot be achieved due to cervical spondylosis, for example, or inability to extend the neck, or difficulty with the general anesthesia, then an open or a flexible approach should be considered. Rigid endoscopy in patients who have short necks or decreased mental distance or have a large body mass index can be difficult. The other thing is very small pouches can be treated better by open approach because endoscopic removal of the septum here carries a higher risk of perforation and mediastinitis. If additional surgery is required to excise the pouch itself because there are concerns about carcinoma in situ, for example, dysplasia or carcinoma, then obviously the open approach should be taken. If there is a need to remove the pouch or suspend it, then the open approach would be preferred. If you have tried one form of therapy, either endoscopically or open, and it failed, then the other approaches can be used in the second attempt. The operation will start with a transverse cervical incision, almost always on the left side. The incision will be deepened through the platysma, and subplatysmal plane will be created and the flaps elevated. The anterior edge of the sternocleidomastoid muscle will be identified, and the carotid sheath will be identified just anterior to this. Dissection then proceeds between the carotid sheath laterally and the larynx and the trachea medially. In this gutter, the dissection proceeds until the prevertebral fascia are reached. This area is crossed by two structures, the omohyoid muscle, and this should be divided at its intermediate tendon, and the middle thyroid vein. This should also be identified, ligated, and divided. And once this is done, the larynx can be rotated anteriorly to expose the back of the pharynx and identify the Cricopharyngeus muscle. The recurrent laryngeal nerve passes close to the muscle in its anterior part, but the myotomy should be placed as well posteriorly in the paramedian position, well away from the recurrent laryngeal nerve. The myotomy itself should extend about 5 to 6 centimeters. It involves dividing all the fibers of the Cricopharyngeus muscle and the lower fibers of the Thyropharyngeus muscle superiorly, and the upper centimeter or two of the esophagus inferiorly. All these fibers should be divided. The pharyngeal mucosa would bulge into the myotomy wound, particularly if the pharynx is packed or if tubing or balloons are placed intrapharyngally. The cut end of the muscle anteriorly can be sutured to other muscle remnants, strap muscle remnants, to avoid the reuniting of the cut edges of the muscle and recurrences of the symptoms. Our surgical modality is the rigid endoscopy. that requires a general anesthesia and also hyperextension of the neck. It was first described more than 100 years ago by Mosher, but standardized and popularized by Dohlman, who also has described some of the instruments used, including his laryngoscope, which has two flanges, a longer anterior flange that would open up the upper esophageal sphincter, and a shorter posterior flange that would push the posterior part of the pouch against the vertebral column. And this would expose the bar of tissue between the pouch and the lumen of the pharynx and the esophagus. And this bar of tissue contains the Cricopharyngeus muscle, and the operation itself would entail either dividing that bar in the midline, or by electrocautery, for example, or stapling or lasers, or having two incisions, paramedial incisions, and excision of the area in between, and this is claimed to reduce the recurrence rate. The endoscopic myotomy starts with the placing of the weirder scope. For example, the anterior blade would stretch the inlet of the esophagus. The posterior blade will rest on the hypopharyngeal posterior wall, and then carbon dioxide laser would be used to divide the muscle itself together with its covering mucosa down to the buccopharyngeal fascia. This is the limit of the myotomy. Once the buccopharyngeal fascia, this should be preserved to avoid any perforation of the pharynx and the esophagus and the potential for developing of mediastinitis. The success rates are quite high for this Dohlman's procedure. In a pooled results of 500 patients, the success rate was almost 93%. Complication rates can be about 8%, but can be as high as 18% in other series, including the most feared complication of perforation and mediastinitis in 2% of the cases. Similar results can be obtained either by carbon dioxide laser or by electrocautery or other techniques for dividing the septum containing the Cricopharyngeus muscle. Another way of doing the rigid transoral approach is the stapling technique. A stapler would be used that is going to cut and staple at the same time both sides of the incision. This is intended to reduce the incidence of perforation and a leak that may cause mediastinitis. The results in a pooled series of more than 1,800 patients showed success rates in excess of 90%, recurrence rates of about 10%, complications of about 7%, again with a perforation rate of about 2%. The other technique uses flexible endoscopes rather than rigid scopes to do the same thing, to divide the septum between the pouch and the lumen of the pharynx and the esophagus, but with the advantage that it would avoid the use of a general anesthesia and also avoid the hyperextension of the neck that can be necessary with the rigid endoscopy. This can be particularly useful in elderly patients who cannot have a general anesthesia, and will also be useful in patients who have spinal stiffness, for example. With the use of the flexible endoscopes, two things can be used to improve visualization in the narrow area of the lower hypopharynx and the upper esophagus. One of them is a soft diverticuloscope, basically a short and soft tube with two flanges that would straddle the Cricopharyngeus septum and opens up the space and make it easier to stabilize and identify the bar of tissue that is to be divided with the use of the flexible scope. The other way is to use a transparent hood on the top of the flexible scope, on the tip of the scope, that was also going to improve visualization in the narrow area in the lower part of the hypopharynx. And then the septum between the pouch and the lumen containing the cricopharyngeus muscle can be divided in any of the several available ways. It can be divided by a needle knife. It can be divided by a hooked knife, which has the advantage of pulling up the muscle fibers before coagulating them and dividing them. It can be divided by lasers. It can be divided by bipolar forceps, harmonic scalpel, or it can be divided by stapling devices. There is no solid data to favor any of these techniques over the other because there are no randomized controlled trials. Also, some endoclips can be placed over the incision area to decrease the chance of shearing of the mucosa of the cut edges of the muscles. Patient can be discharged home the same day, and they can be allowed things like liquids on day 2 and soft diet on day 3. A large meta-analysis study of the outcomes of flexible endoscopic approach showed that the success rates are very comparable to the rigid endoscopic approach or the open surgery approach, with success rates of about 92%. Most of the involved studies had higher success rates. There was only one single study that had about 58% success rate. The complications and adverse events were around 13%, and the recurrence rate was about 14%. The most feared complication, of course, is the perforation and the potential to cause a mediastinitis. But other complications can happen, including a fistula, wound infection, stenosis of the pharynx, a residual or a recurrent pouch, and sometimes, rarely, the recurrent laryngeal nerve can be injured. An important modification for the flexible endoscopic approach was the creation of a submucosal tunnel. Now, rather than dividing the septum between the pouch and the lumen directly, a small submucosal tunnel, like a flap, is created by opening up a small incision in here, elevating the mucosa as an intact cuff, dividing the muscle directly, and then replacing the mucosa on top of it afterwards. It's claimed that this would reduce the chance of a perforation and helps with the healing. They have a lower complication rate and a very comparable success rate. And finally, there is this issue of the reported carcinomas and carcinomas in situ within a pharyngeal pouch mucosa. It's quite rare. At one point, there were only about 45 cases reported in the English language literature, but it's now estimated that about 2% of the pouches may have either a carcinoma or a carcinoma in situ. It's very difficult to diagnose it before surgery, but most of them would be diagnosed after clearing of the pouch from any retained food during surgery. But carcinomas in situ may not be discovered except after surgery with the histopathology examination of the excised pouch mucosa. This is one argument in favor of excising the pharyngeal pouch rather than just dividing the septum between the pouch and the lumen of the pharynx and the esophagus. By this, we come to the end of this presentation on pharyngeal pouches. Assalamu alaikum.